I guess I'm bringing it back to more real life in terms of what we see in the clinic. I will tell you up front, there is going to be no complicated integrase resistance here because Jonathan is the expert on it and has already told you pretty much everything you need to know. But certainly on the last points that were made after Laura's presentation just now, my case follows on really quite beautifully. Anybody would think we'd planned it. So it's quite an interactive case, so it'd be really useful for people just to speak up as we go along. So basically, this is a lady who we saw at the beginning of this year, a 46-year-old Polish lady with pretty limited English, has a wonderful 22-year-old daughter who is her translator, her advocate. She's amazing. She'd last tested 6 years ago, no blood products, no IV drug use, and her regular partner is from Sierra Leone. That's a good start. The end. So she'd had 3 emergency department attendances over the previous year at a Greater London hospital, complaining of 20-kilo weight loss. She's quite a large lady anyway, so 20-kilo weight loss probably wasn't viewed as massively significant, actually. She would complain of tiredness, oral thrush, recurrent respiratory infections, and on bloods she had leukopenia and anemia. And on every visit, she was given oral antibiotics and antifungals, wherever that's gone, and had clinical improvement each time. So most of you will probably be familiar with the HIV Indicator Conditions, which is Europe-wide, basically guidance on HIV testing in various healthcare settings. And I knew that probably wouldn't come up very well, but basically I've just circled the problems that she attended with, which was that she did have community-acquired pneumonia, she did have oral thrush, she had obviously hematological problems, and she had unintentional weight loss. So the team at that hospital had a discussion with our team. She'd had a HIV antibody test finally done at that hospital, which was antibody positive, but when she transferred to us, she wasn't aware of that. She was admitted, and she was also found to have esophageal thrush. So her baseline bloods, we know.
I think the animations are set wrong. They show for a fraction of a second and then they...
So I'll tell you the baseline bloods then. She was HIV antibody positive, as I've already said. She had a CD4 count of 6, 2.4%. She had a HIV viral load of 600,000. Her HLA-B5701 was negative, and she was Hep C antibody negative, Hep B acquired immunity. So based on those results, who is going to start treatment right now? Yes, I mean, our BEVA guidelines say that we've got within 2 weeks, but the decision was taken to start treatment straight away. What will you give her? Will you give her Truvada raltegravir, Truvada darunavir ritonavir, abacavir 3-TC ral, abacavir 3-TC dolutegravir, abacavir 3-TC darunavir ritonavir, or, for good measure, Truvada efavirenz? So first option.
Breda, can you just remind everyone what the viral load?
626K. So pretty high viral load. So would anybody go for Truvada raltegravir? Truvada darunavir ritonavir? Kivexaral? Hopefully nobody. Triamec? Kivexadarunavir ritonavir, or Truvada favorans.
Yes, second option. Could we give her Truvada dolutegravir in 2 pills?
Well,
Is that allowed here?
it's
Yes.
it's very tricky. It's a possibility, because everything's a possibility when we're doing a presentation, so it is a possibility.
That's the most, in many places, that's the most commonly used.
Okay.
And actually, it's 2 pills, but Truvada dolutegravir in many countries is actually the most used for
Yeah.
prevention. So I guess it's legal issues and financial.
Yes. Well, exactly. Long time ago in HIV land. So this is just a snippet from her medical notes, which clearly the plan was to start Truvada darunavir, but somebody had a last-minute change of heart and decided to give her valtegravir 1200 once a day. Okay? So she was seen. So our setup at Chelsea is that we have our own inpatient unit with a daycare unit attached, and she'd been admitted for a few days, and her follow-up post-start, because obviously she'd been fairly unwell, was within the daycare unit, and she was seen there a month later. And she was feeling much better. She'd gained 7 kilos. Her CD4 had increased from 6 to 103. Her anemia was improving. Not at the end. And she had a viral load response of 626,000 down to 1,232. Are we happy with this response? Any reason not to be? No, I think we were pretty happy, and Beaver agrees. So an ART response is accurately predicted by a 3-fold or more viral load decrease at week 4 after starting treatment. So we were pretty happy with that. And at this point, so the lady, she came back for 8-week follow-up as well, and that was the first time that I met her in outpatients. And I was clearly feeling slightly frivolous with NHS money that day. And for reasons that remain unclear to me, I did a viral load at 8 weeks. I still, to this day, don't really know why I did it. I had a 6th sense, maybe. But her viral load that day was 1,285. So very similar to what it was after 4 weeks. So I discussed that with some of my senior colleagues. We have a really nice setup where we have pre-clinic meetings before all our sessions, where everybody who's seeing patients that day comes to discuss their patients and present patients and any problems, and it's a really good education opportunity as well. And 2 of my senior consultants were not overly concerned by this. And despite working within a very good multidisciplinary team, I chose to ignore them, and I spent a bit more NHS money and sent off a viral resistance test. So at this point, she denied any adherence issues. And she's a very straight down the line woman who, if I have to do this, I'm doing this. Why on earth would I not do it? And I'd only met her once, but it was one of those situations where I had no reason not to believe her. And her daughter was very involved in her care, to the point of, I think, nagging her to take her medication. And I had no reason not to be convinced. She wasn't on any co-meds that we didn't already know about, other than all her OI prophylaxis. So I just thought I'd go back and look at a baseline resistance test, which nobody has mentioned as yet, as neither have I. And that was where her baseline viral resistance test was. It did not exist. That wasn't an animation problem. So going back to the setup, she had it requested while she was an inpatient, and she was with us for, say, 2 days and discharged. She was seen in our daycare setting a month later, had a really fantastic viral response, and was probably seen by somebody else after that month who didn't think checking the viral checking the baseline resistance test was required, given there was such a good viral load response. So at this point, I requested, as I say, a VRT on her most recent viral load result, which was that 1285. And this was it. So obviously there was no PI resistance because she wasn't on any, but clearly we didn't have a pre-existing one either, so there could have been. And we saw an M184V on NRTI. I had a problem getting her integrase resistance on here yesterday, but believe me when I say there wasn't any. So the only mutation she had was an M184V.
So this is why we prefer giving Truvada to a Bacteria 3TC. It's right here. The impact of having 184, if you're giving Triomeg or giving Truvada dolutegravir, and I think this is the perfect case for showing it, is the opposite. So if you see here, both the Bacavir and the Limivudine are impacted by 184 in a negative way. You see they both have a score there on the Stanford. They both have a score of 15, a bad score. So I actually have two drugs where one mutation, which is very common to select for, impacts them both in a negative way. If you scoot down and look at tenofovir, and if you look at tenofovir, it actually goes the other way. 184 hypersensitizes. Hence, what I mentioned, that's exactly the reason that many of us prefer giving the two drugs, but getting a much better resistance protection than giving it. Now, it's true that in most cases, when you give dolutegravir, and it's such an overpowering drug, it's fine. But the significance of having a baseline resistance test is very high. If you're giving drugs, like raltegravir, but if you're giving dolutegravir, tenofovir, 3TC, it's different than if you're giving it. So this is an extreme case, and usually it's fine, but I think it's a very good case that teases out these issues.
Yeah. So just following on from that, so the M184V, as I think probably most people in the room know, so it's revision really, viruses that harbour the 184 don't replicate that well. They're less fit viruses, hence why we saw such a pretty fantastic viral load drop, which actually the next one I think was on this viral load sample was about 300, I think. The M184V causes marked phenotypic resistance, but it doesn't translate clinically. And as Jonathan just said, we see improved susceptibility to tenofovir in terms of drugs that we currently use and AZT and D4T back in the olden days. And in terms of emergence of resistance with declining viral loads, we know it's possible. It's especially more pronounced in people who experience slower viral load declines, which I'm not convinced we could say that was the case with this person. And in terms of this study, which again in HIV years is about 1,000 years old, but intensification may be a worthwhile strategy. And I struggled to find very much more recently in terms of what would be recommended in a situation like this. So after much liaising with our virology lab, we finally did get the baseline resistance test processed, which actually showed no mutations at all. She had no NRTI mutations to begin with, and no integrase. So actually, she did have a wild-type virus to begin with. So this did happen with a declining viral load. So what would you do now? I think I know what some people would do. Would you intensify?
Switch to protein,
We actually did intensify at this point. We gave her, and it was a virtual clinic, kind of quite a large team decision to give her, to intensify with darunavir until she became undetectable, which I think she was within the next month. And in fact, yes, she was undetectable so actually seeing her response coming down, and I think it was probably the June result of 69 where her treatment was finally switched, and she was undetectable in August on a new regimen. So lessons learnt, know your HIV indicator diseases, which my caveat at the bottom says, I know I'm preaching to the converted, but it's clear, that this was 2018, it wasn't 5 years ago, and it was a Greater London hospital, so slightly concerning to say the least. We know baseline viral resistance tests should be performed and appropriately checked in all patients before starting antiretrovirals, or as close to that time as possible. And the emergence of an isolated 184 could be missed due to an acceptable viral load decline. And I know this is quite an unusual case that it did happen in isolation, and she had such a good viral load response. But clearly, given what Jonathan was saying, if she had continued, then we are pretty much bound to have seen raltegravir resistance probably fairly soon. Yeah. And unusually for me, I have finished before I even need to. So yes, it would seem that we do have time for questions if anybody has some.